Most exanthems present as an isolated episode in a single child, but outbreaks can also develop in groups of children. When evaluating only a single child with a rash, the diagnosis can usually be made by routine history and physical examination. When several children develop similar appearing skin lesions, obtain detailed contact and exposure history, and consider the need to involve specialty service. Ask about the initial location of rash, the pattern and time frame of rash development, initial morphology, and whether any topical or systemic medications have been applied. Also inquire about fever and systemic symptoms, prior immunizations, potential human or animal contacts, recent bites or stings, travel, recent prescription or over-the-counter drug administration, and recent food and environmental exposure. Perform a complete physical exam and obtain a full set of vital signs. Completely disrobe all patients and place in a gown. Examine patients in a room with good lighting to avoid missing important findings. Most rashes are self-limited and benign in children, but some rashes may be the harbinger of serious illness. An ill-appearing child or a child with a non-blanching rash raises suspicion for a serious condition. Check the scalp, ears, neck, mucous membranes, all skin folds, digits and web interspaces, palms, and soles. Look for ticks that may be adherent in hair-bearing areas or skin folds. Identify the morphology and determine the location and distribution of the rash. Enteroviruses are a very common cause of illness and rash in young children. Enteroviruses are small, single-stranded RNA viruses belonging to the picornavirus group and include polioviruses, coccicevirus, and echovirus. The enterovirus family has been associated with a wide variety of illnesses, including polio. Enterovirus infections usually occur in epidemics, with a peak prevalence in the summer and early fall. Transmission usually occurs by the fecal-oral route and sometimes by respiratory or oral transmission. The clinical signs and symptoms of infection with cocciceviruses and echoviruses vary and can include nonspecific febrile illnesses, upper and lower respiratory infections, GI infections, aseptic meningitis, or myocarditis. Similarly, the associated skin manifestations include an array of exanthems, diffuse macular eruptions, morbilliform erythema, vesicular lesions, petechial and procuric eruptions, rubelliform rash, roseola-like rash, and scarlatiniform eruptions have all been reported. Strict clinical virologic associations are difficult to demonstrate, unlikely to be practical in the ED, and equally unlikely to change the course of management. Infection due to echovirus 9 or coccicevirus A9 is common and produces typical examples of exanthems secondary to enteroviral illness. Both viruses may produce a maculopapular rash beginning on the face and neck and then extending to the trunk and feet. The palms and soles are also sometimes affected. Clinical manifestations include fever that may be accompanied by headache, GI complaints, and upper respiratory symptoms. With echovirus 9, occasionally, there are lesions on the buccal mucosa and soft palate that resemble complex spots. Petechiae may develop, raising concern for meningococcemia, although the petechiae due to enterovirus do not typically coalesce or progress to purpura. The exanthem persists for approximately 5 days. The exanthem of coccicevirus A9, by contrast, may be vesicular or urticarial. Aseptic meningitis may be present. Another common rash caused by an enterovirus is hand, foot, and mouth disease. Initial signs and symptoms include fever, anorexia, malaise, and sore mouth. Oral lesions appear 1 to 2 days later, and cutaneous lesions appear shortly thereafter. The oral lesions begin as vesicles on an erythematous base, which subsequently ulcerate. The vesicles are usually 4 to 8 mm in size and are very painful. They are located on the buccal mucosa, tongue, soft palate, and gingiva, figure 142-1. The exanthem starts as red papules that change to gray vesicles approximately 3 to 7 mm in size. They are found on the palms and soles, but may occur on the dorsum of the feet and hands and on the buttocks as well, figure 142-2. They may be oval, linear, or crescentic and may run parallel to skin lines. They heal in 7 to 10 days. Recent cases have been reported of pediatric patients presenting with onychomedesis, proximal shedding of nails due to nail matrix arrest, several weeks, average 6 weeks, after an illness consistent with hand, foot, and mouth disease. It is helpful to be aware of this increasingly common complication in order to reassure parents of the benign nature of the condition. A particularly severe form of hand, foot, and mouth disease, attributed to enterovirus 71, has been identified in Southeast Asia and has been associated with serious illness including encephalitis and death. Clinicians caring for patients from this region or those having traveled to the area should be mindful of potential deterioration of these patients. Another recent strain that is circulated in many countries including the United States is enterovirus D68. This strain has been associated with more severe disease including severe respiratory complications and acute flaccid myelitis presenting as paralysis in pediatric patients. These newer more virulent strains have prompted further research into a possible vaccine for enterovirus. A similar syndrome of fever, mouth pain, and oral ulcers is caused by other subtypes of the coccicevirus group A and is known as herpangina. Like hand, foot, and mouth disease, the diagnostic finding is small whitish ulcers, typically located on the soft palate and posterior pharynx, without accompanying skin lesions, figure 142-3. The clinical differentiation of enteroviral disease is difficult, but because there is no specific therapy for enteroviral infection, it is more important to consider bacterial diseases in the differential diagnosis to exclude treatable causes of sepsis, meningitis, myocarditis, and pneumonia. Enteroviral polymerase chain reaction testing is commonly available and may be useful in cases of meningitis in which viral testing may decrease length of hospital stay and use of antibiotics. Symptomatic therapy for enteroviral infections includes hydration, antipyretics, and topical oral pain relief preparations. Combinations of Maalox registered trademark, or similar, and if anhydrine liquids applied with a cotton swab to the painful oral lesions may be useful. This combination may be used orally as well, being mindful of weight-based dosing for both medications. Oral therapy with acetaminophen and ibuprofen has also proved helpful for pain control. Viscous lidocaine should not be used. A recent U.S. Food and Drug Administration drug safety communication advises that viscous lidocaine 2% solution should not be used in infants and children. In 2014, 22 serious adverse events, including deaths, in children aged 5 months to 3.5 years were attributed to the use of oral topical viscous lidocaine. Rarely, analgesia with oral narcotics is needed to prevent dehydration. Hospitalization in patients requiring this level of pain relief may be considered. The number of measles cases in the United States in 2013 to 2014 was the highest since 2000. Recent outbreaks among adults and children in many states have been attributed to international travel and unvaccinated populations here in the United States. Thimerosal was taken out of childhood vaccines in 2001, and multiple, large, well-designed epidemiologic studies and systematic reviews have found no evidence of an association between thimerosal and autism or other developmental disorders. In fact, autism rates have continued to rise, which is the opposite of what would be expected if thimerosal caused autism. Serious complications of measles have been reported, including encephalitis, bacterial infections such as pneumonia, and death. These complications are more common in children under the age of 5 years than school-age and adolescent patients. All medical care providers must be able to identify the exanthem and enanthem typical of measles in any patient presenting with the undifferentiated rash. Measles virus, rubella, is a member of the family Paramyxoviridae, genus Morbillivirus. After exposure, the incubation period for measles is approximately 10 days, range 7 to 21 days. The prodromal period lasts approximately 3 days and is characterized by fever, malaise, and anorexia, followed by conjunctivitis, coryza, and cough. The severity of conjunctivitis is variable and may also be accompanied by lacrimation or photophobia, but is typically not exudative. The exanthem develops approximately 14 days following exposure. The rash first appears behind the ears and at the hairline of the forehead and then spreads cephalocaudally and centrifugally to involve the neck, upper trunk, lower trunk, and extremities sparing the palms and soles. It initially consists of erythematous blanching maculopapular lesions but rapidly coalesces, especially where the first lesions appeared on the face, figure 142-4. In general, the extent and degree of confluence of the rash correlate with the severity of the illness in children. Other rash-causing diseases often confused with measles include rosella infantum, see figure 142-12, and rubella, German measles, see figure 142-6. AC measles. An 8-month-old child presented with fever, coryza, and marked conjunctivitis associated with intense photophobia. Confluent, erythematous, and maculopapular rash on the face developed on the 4th day of fever. He developed measles during the measles outbreak seen in New York City in 1993. For A and B, used with permission of Benita or Shaw, MD reproduced with. Search carefully for Koplik spots, figure 142-5, in patients with suspected measles, because they are pathognomonic for measles infection and occur about 48 hours before the characteristic exanthem. However, they do not appear in all patients. Treatment is supportive. Recognition is of the utmost importance in preventing the spread of the disease and associated morbidity and mortality. Immunization remains the most important preventive measure. About 1 in 20 children who receive the measles, mumps, rubella, and varicella vaccine will develop a rash following vaccination, which may prompt a trip to the ED. The rash usually involves the trunk and face, is macular and blanching, does not involve systemic symptoms, and is self-resolving. The only treatment is reassurance. Rubella, German measles, or third disease was once a common childhood disease that had its highest incidence during the spring. The incubation period is 12 to 25 days following exposure, with a 1 to 5 day prodrome of fever, malaise, headache, and sore throat. The exanthem varies and is sometimes difficult to identify. It may be a short-lived blush, or it may have a more typical and protracted 2 to 3 day course. The exanthem begins as irregular pink macules and papules on the face, spreading to the neck, trunk, and arms in a centrifugal distribution, figure 142-6. The rash coalesces on the face as the eruption reaches the lower extremities and then clears in the same fashion. 4 Clymer spots are pinpoint putaceae involving the soft palate that coalesce and may accompany the rash but are nonspecific. Lymphadenopathy is a clinical manifestation of rubella, with characteristic enlargement of suboccipital and posterior auricular nodes. The clinical diagnosis in an individual case is often difficult, but the epidemic nature of the illness, along with the seasonal variation and high expression rate of the exanthem, help in establishing the diagnosis. A history of inadequate immunizations may assist in the diagnosis. There is no specific therapy. Fifth disease, or erythema infectiosum, is an acute, febrile illness with a unique exanthem. Outbreaks of erythema infectiosum occur primarily in the spring. During epidemics, the attack rate is highest in children 5 to 15 years of age, but all age groups can be affected. The illness is caused by infection with human parvovirus B19, a single-stranded DNA virus. The abrupt appearance of the rash is frequently the first manifestation of erythema infectiosum. It begins with a characteristic fiery red rash on the cheeks, figure 142-7. The rash is a diffuse erythema of closely grouped tiny papules on an erythematous base. The edges are slightly raised. The erythema is most intense below the eyes and extends over the cheeks in a pattern reminiscent of butterfly wings. It is sometimes referred to as a slap cheek appearance. There is subhumoral pallor as well as smearing of the eyelids and chin. The facial rash fades after 4 to 5 days. Approximately 1 to 2 days after the appearance of the facial rash, a non-periodic macular erythema or erythematous maculopapular rash occurs on the trunk and limbs. It is at first localized to the deltoid areas, trunk, and forearms, but usually extends to involve a large area. This stage of the exanthem may last 1 week. A distinctive aspect of the rash is that it fades with central clearing, giving a reticulated or lacy appearance, figure 142-8. The palms and soles are rarely affected. The exanthem may recur in the ensuing 3 weeks, sometimes briefly. The intensity of the recurrent exanthem varies and may be related to exposure to environmental factors such as sunlight, hot baths, and, perhaps, physical exertion or emotional upset. Associated symptoms frequently occur and may include fever, malaise, headache, sore throat, cough, coryza, nausea, vomiting, diarrhea, and myalgia. Arthralgia and arthritis can occur, but are more common in adolescents and adults in whom symptoms can be severe. Parvovirus infection may also be severe in patients with sickle cell disease, in whom it may precipitate a plastic crisis. Fetal anemia and hydrops may also occur with acute infection in pregnant women in the first half of pregnancy, and those who have been exposed should be counseled appropriately. In general, parvovirus infection requires only symptomatic therapy, and recovery is usually complete. The two serotypes of herpes simplex virus, HSV, are HSV1 and HSV2, which are double-stranded DNA viruses that can present variably based on the organ systems involved and the competency of the host's immune system. Infections may be disseminated, localized to the CNS, or mucocutaneous. In the infant, HSV2 is usually contracted during childbirth through vaginal secretions. HSV1 is typically spread through oral secretions. The incubation period for herpes is from 2 to 14 days. With both serotypes, viral shedding may occur from an asymptomatic source. HSV1 is the most common type identified in lesions of the skin and oral mucosa, but HSV2 has also been identified. Off-inoculation may also occur. The clinical appearance of both serotypes is indistinguishable, and this point is important when there is concern for sexual abuse. HSV persists for life in a latent form, with a possibility of both symptomatic and asymptomatic reactivation. Visually identifiable lesions presenting to the ED may include oral lesions, skin lesions primarily of the hand or genitalia, or ocular lesions. Herpes labialis, cold sores and gingiva stomatitis are two common mucocutaneous presentations of herpes in children and young adults. Figure 142-9. A lesion may be single, or lesions may be clustered or, in the case of gingiva stomatitis, may be evident diffusely throughout the oral cavity. The clinical appearance of most herpetic infections is of umbilicated vesicles that are extremely painful. They eventually unroof and crust over. Labialis is typically localized to the vermilion border. Gingiva stomatitis causes erythematous edematous bleeding gums that may make eating and drinking painful. As stated earlier, viscous lidocaine preparation should not be used. Eczema herpeticum, figure 142-10, is the development of vesicular eruptions in the areas of the epidermis previously affected by eczema and may be life-threatening. Although fever may present with other forms of HSV infections of children, fever is described more frequently with eczema herpeticum. Examination reveals skin with punched out erosions, hemorrhagic crusts, or vesicles. Treatment includes oral antibiotics to treat staphylococcus and streptococcus. See table 142-2 regarding antibiotics for cellulitis, as well as antiviral therapy with acyclovir, 80 mg per kilogram d every 6 hours for 10 days. Another herpetic skin manifestation is herpetic whitlow. This infection of the distal fingers is usually the result of inoculation from an oral infection. Carefully examine the child's eyes to ensure that no herpetic lesions are present on the cornea secondary to direct contact. Herpetic infections of the ears, thorax, and extremities have also been reported as a result of close contact sports, wrestling. Genital infections are most commonly the result of sexual transmission, consensual or abuse. Diagnosis is usually based on the clinical appearance, but viral cultures should be obtained for confirmation, particularly when sexual abuse is a consideration. Obtain cultures from the fluid of an unroofed vesicle. Culture, enzyme-linked immunosorbent assay, direct fluorescent antibody testing, and polymerase chain reaction are acceptable forms of testing. Providers should confirm with their laboratories the preferred method of sampling at their institution. Treatment in the case of oral lesions is symptomatic. Oral antivirals may shorten the course of an acute outbreak and viral shedding when provided early in the disease, first 48 hours. Topical acyclovir is ineffective. Limited data suggests that children with herpetic gingiva stomatitis presenting early in the course, 72 to 96 hours of disease onset, who are unable to drink or have significant pain may benefit from oral acyclovir. The dosing of oral acyclovir is variable based on age, immune status, and location of lesions. A typical dosing regimen suggested by the American Academy of Pediatrics for Children and Adolescents is as follows: PO 80 mg per kilogram D in 4 divided doses for 5 to 7 days. Usual maximum dose, 3200 mg D. This regimen has been shown to be helpful in shortening the duration of symptoms. When initiating antiviral medication in children less than 2 years old or in immunocompromised children, dosing is more variable, and consultation with a pediatric or infectious disease specialist is appropriate. Ophthalmology should be consulted when herpetic lesions are suspected of having invaded the cornea. This may be evidenced by dendritic-appearing lesions with flu or stain staining. Varicella, or chickenpox, is a result of infection with varicella zoster virus, a herpes virus. In normal children, it is characterized by a pruritic generalized vesicular exanthem with mild systemic manifestations. Cases generally occur in late winter and early spring. It is highly contagious in the prodromal and vesicular stage. Varicella most frequently occurs in children less than 10 years old but may occur at any age. The rates of varicella and associated hospital admissions and deaths have declined dramatically in surveillance areas with significant vaccine coverage, but cases do occur in vaccinated children, although they are typically mild and more limited than in unvaccinated children. Severe side effects from the vaccine are rare. Varicella starts on the trunk, and most lesions are clustered in this body region. Lesions are of different stages presenting simultaneously. Within 24 hours, the rash acquires the typical vesicular appearance of varicella. The rash consists of teardrop vesicles on an erythematous base, which then dry and crust over. Successive fresh crops may appear for a few days. The extent of the rash may be minimal, but usually it will spread centrifugally and become widespread. Figure 142-11. Palms and soles are spared. Vesicles may occur on mucous membranes and go on to rupture and form shallow ulcers. Atypical and limited cutaneous involvement may occur among immunized children infected with varicella virus. Low-grade fever, malaise, and headache are frequently present but are usually mild. The diagnosis of varicella is usually made clinically based on its distinctive rash. A Zank smear of the vesicle contents may demonstrate varicella giant cells with inclusion bodies. Polymerase chain reaction may also be performed on skin scrapings. Fluorescent antibody to membrane antigen testing is regarded as the gold standard for identification of varicella zoster virus antibodies, but is not readily available. Complications of varicella include encephalitis, pneumonia, hepatitis, and bacterial superinfection of the ruptured vesicles with staphylococci or streptococci. Neonates born to mothers with perinatal varicella infection may develop serious illness. Uncomplicated varicella requires no specific therapy. Acetaminophen may be used as needed. Do not give aspirin because it may predispose to the development of Reye's syndrome. Oral antihistamines may be useful to reduce itching. Over-the-counter oatmeal-based baths may provide temporary symptomatic relief. Clean lesions regularly to prevent secondary infection. In the absence of CNS complications, the prognosis is excellent. Routine use of antiviral therapy for uncomplicated varicella infections in immunocompetent children is not commonly recommended. Oral acyclovir, 80 mg per kilogram D divided every 6 hours for 5 days. Maximum dose, 3,200 mg, may be considered if started within 24 hours of onset for children over the age of 2 years or at increased risk of moderate to severe complications. This includes unvaccinated children over the age of 12 years, children on long-term salicylate therapy, and children on short. Infants and immunocompromised children with varicella require aggressive treatment with acyclovir. Those less than 1 year of age are treated with 10 mg per kilogram every 8 hours, whereas children older than 1 year receive 500 mg per meter every 8 hours. Administration of varicella zoster prophylaxis should be considered for patients exposed to individuals with varicella if provided within 3 days of exposure. Introduction. Select to favorite. This chapter describes disease processes in children for which dermatologic symptoms. Infants and immunocompromised children with varicella require aggressive treatment with acyclovir. Those less than 1 year of age are treated with 10 mg per kilogram every 8 hours, whereas children older than 1 year receive 500 mg per meter every 8 hours. Administration of varicella zoster prophylaxis should be considered for patients exposed to individuals with varicella if provided within 3 days of exposure. Rosella infantum, or Exanthum subtitum, was previously called 6 disease. There is no seasonal association. The most likely cause is the human herpes virus 6, although other viruses have been associated with the Rosella-like illness. Rosella is characterized by a febrile period of 3 to 5 days, defervescence, and the appearance of a rash for 1 or 2 days, figure 142-12. The appearance of the rash immediately following a non-specific febrile illness is characteristic and aids in the diagnosis. Primarily, young children are affected, with most patients being between 6 months and 3 years of age. The illness begins abruptly with high fever, sometimes as high as 40.6 degrees Celsius, 105 degrees Fahrenheit. The child is usually alert and active but may be irritable, especially with very high fever. Associated symptoms are usually mild and may include cough, coryza, anorexia, and abdominal discomfort. Lymphadenopathy may be present. The fever persists for 3 to 5 days, and the child rapidly becomes well. Although the exanthum in Rosella usually coincides with defervescence, the rash may follow a short off-febrile interlude. The rash is an erythematous macular or maculopapular eruption that consists of discrete, rose or pale pink lesions 2 to 5 mm in size. It is most prominent on the neck, trunk, and buttocks, but the face and proximal extremities may also be involved. The lesions blanch with pressure. There is no mucous membrane involvement. The rash lasts 1 to 2 days but may fade rapidly, usually without desquamation. Tinea refers to a broad spectrum of skin infections caused by dermatophytes. These spore-forming organisms invade the stratum corneum and proliferate by feeding on keratin. These superficial infections can affect the nails, skin, scalp, and hair and are named for the area of the body infected. Tinea carpitis, scalp, and corpus, skin, are the 2 most common infections in younger children. Carpitis is most common in children less than 10 years of age with a peak of 3 to 7 years old. Corpus is also common and may be seen in adolescents participating in contact sports. Tinea pedis, foot, and tinea crurus, groin, also occur in children. The affected areas are typically scaly and vary with a degree of pruritus from intense, as with crurus, to barely present, corpus. Tinea corpus commonly has a ring appearance with central clearing. Tinea carpitis causes patchy alopecia as the hair follicles are invaded and lose their structure, causing them to break at the base, figure 142-13. A more severe form of carpitis, known as carrion, may occur when there is an exaggerated inflammatory response producing a painful, boggy mass, figure 142-14. Occipital and posterior auricular lymphadenopathy are common physical findings with a high positive predictive value for tinea carpitis. The differential diagnosis of a tinea infection includes pityriasis rosea, lichen planus, psoriasis, eczema, and contact dermatitis. Diagnosis can be aided by direct microscopic observation for high P. Wood lamp evaluation is not very useful, because many dermatophytes do not fluoresce. Treatment is typically topical, with the exception of tinea carpitis. Some forms of tinea that do not respond to topical treatment may also require oral therapy. For topical treatment, therapy is usually continued for 7 to 10 days beyond resolution of the lesions, which may take 2 to 3 weeks to fade. Multiple topical therapies are available by prescription or over the counter, table 142-1. The treatment of choice for tinea carpitis is griseopelvin, age greater than 2 years old. Microsize 20 to 25 mg per kilogram D divided every 12 hours or ultra microsize 10 to 15 mg per kilogram D also divided every 12 hours. Baseline lab testing is not necessary with griseopelvin. If treatment is to extend beyond 8 weeks, then check complete blood count and liver and renal function tests. Children with a painful carrion may be treated with prednisone 1 to 2 mg per kilogram D for 1 week in addition to systemic antifungal therapy. Terbinafine, less effective than griseopelvin for microsporidium species, itraconazole, and fluconazole are also effective, with shorter courses of treatment, but are expensive. Selenium sulfide 2.5% and ketoconazole shampoos are excellent adjunct therapy. Both should be left on the scalp for approximately 5 minutes to improve effectiveness. There is no recommendation for exclusion from school, because there is a high incidence of asymptomatic carriers and spores may be spread for months. Tinea carpitis and, rarely, tinea corpus may be associated with a papular hypersensitivity dermatitis, dermatophytic reaction, or id reaction. These papules or vesicles, having varying degrees of inflammation, may be pruritic. The lesions are seen on the face, trunk, and extremities of children with tinea carpitis at the time of the diagnosis or, more commonly, after initiation of systemic therapy. This rash is a manifestation of an immune response and is not a drug reaction. Oral antifungal treatment should be continued, and topical corticosteroids or systemic antihistamines are used as needed. Impetigo is a superficial infection caused by either Staphylococcus aureus or B. hemolytic streptococci, figure 142-15. Impetigo can arise at the site of insect bites or superficial cutaneous trauma. Sometimes, there is no apparent predisposing skin lesion. Lesions occur most frequently on the face, neck, and extremities. Fever and systemic signs are uncommon. Diagnosis is made on clinical appearance that takes two forms. In non-bullous impetigo, more common, skin lesions start as small erythematous macules and papules that develop into discrete, thin-walled vesicles, which become pustular and quickly rupture. As the vesicles rupture, a yellow fluid forms and exudate, which dries to form a stratified golden yellow crust that can spread the infection to other parts of the body. The crust can be readily removed, leaving a smooth, red surface. Initially, the lesions are discrete, but they may enlarge and become confluent. Local adenopathy may be present. Cultures are only necessary in patients who fail to respond to standard therapy. Eczema is a deeper infection than impetigo, and soreness and less commonly streptococci may be the cause. Lesions begin as vesicles that rupture, resulting in circular, erythematous, punched-out ulcers with adherent crusts that can resemble a cigarette burn, often with surrounding erythematous edema. Treatment is aimed at preventing spread and eradicating the offending agent. Appropriate cleansing and general hygiene are mandatory. Mutharustin ointment, 2% applied 3 times a day for 7 to 14 days, is the topical antibiotic of choice for localized areas of infection. Cephalexin or clindamycin is given when large areas are affected or topical coverage is impractical. Table 142-2. Toxin-mediated erythrodermas, including bullous impetigo and Staphylococcus scalded skin syndrome, are part of the spectrum of the same disease. Although the lesions of bullous impetigo are local at the site of infection, those of Staphylococcus scalded skin syndrome are distant and widespread. Toxin serotypes A and B produced by Staphylococcus are the causative agents for the exfoliative presentation. In bullous impetigo, the epidermolytic toxin acts locally to cause separation of the skin at the granular layer, giving rise to bullae. The infection occurs primarily in newborn infants and young children. The characteristic skin lesions of bullous impetigo are superficial, flaccid, thin-walled bullae that occur most often on the extremities but can occur anywhere. Bullae range in size from 0.5 to 3.0 cm. They can arise from normal skin or may have a thin, red halo. The bullae are filled with a clear, pale to yellow fluid and rupture easily, leaving a moist, denuded base that dries rapidly with a shiny coating. Figure 142-16. Extensive areas of skin may be involved if left untreated. The clinical appearance of the lesions usually makes diagnosis less complicated. The rash is localized to one area of the body and these children are not typically systemically ill. In most cases, bullous impetigo may be treated locally and as an outpatient. Topical or oral agents directed at both methicillin-sensitive aureus and streptococcus are recommended. Treatment consists of oral dicloxacillin, cephalosporin, or clindamycin if methicillin-resistant aureus, MRSA, is suspected. Table 142-2. Staphylococci cultured from the fluid of aspirated bullae will establish the diagnosis. Staphylococcus scalded skin syndrome occurs primarily in children under the age of 5 years, and outbreaks in nurseries have been reported. Children are irritable and febrile, as compared to bullous impetigo where systemic symptoms are lacking. The rash appears as generalized, tender, macular erythema that is most prominent on the skin around the mouth and nose and in intertriginous areas. Within 1 or 2 days, the rash begins to peel. The large superficial flaccid bullae are then unroofed, revealing areas of erythematous and shiny skin, which then crust and heal. Figure 142-17. Nikolsky sign, separation of the epidermis when pressure is applied, is present with Staphylococcus scalded skin syndrome. Obtain cultures of blood, urine, nasopharynx, and cutaneous lesions. Treatment often requires inpatient therapy, fluid resuscitation, and parenteral antibiotics. Patients with diffuse disease should be admitted to a burn unit for further care. Patients with localized infection may be discharged to home with appropriate follow-up. Parental nafcillin, oral dicloxacillin, penicillin G-procaine, amoxicillin clavulanate, cefazolin, and cephalexin are all acceptable therapies. For methicillin-resistant aureus, options include clindamycin, trimethoprim sulfamethoxazole, or vancomycin. Coverage is often provided for both methicillin-sensitive and methicillin-resistant aureus. Table 142-2. Second disease, or scarlet fever, is an acute febrile illness, primarily affecting young children, caused by Group A B hemolytic streptococci. Group C streptococcus has been implicated as well. Clinical manifestations include acute onset with fever, sore throat, headache, vomiting, and abdominal pain followed by a distinctive exanthem in 1 to 2 days. There is both an ananthem and an exanthem associated with scarlet fever, caused by an erythrogenic toxin elaborated by the streptococcal organism. The tonsils and pharynx are red and covered with exudate, although, occasionally, pharyngeal findings are minimal. The tongue may develop a white coating through which red and hypertrophic papillae project, creating the appearance of a white strawberry tongue. The white coating disappears by day 4 or 5, and the tongue acquires a bright red appearance, the red strawberry tongue. Figure 142-18. Bright red or hemorrhagic spots may be seen on the soft palate or anterior pillars of the tonsillar fossa. The exanthem of scarlet fever begins 1 or 2 days after the onset of the illness. It starts on the neck, oxylae, and groin and spreads to the trunk and extremities. Figure 142-19. The rash is red and finely punctate, consisting of 1 to 2 mm papules that blanch and have a characteristic rough, sandpaper feel. It is sometimes easier to identify the rash by palpation. Linear petechial eruptions, pastia lines, are often present in the antecubital and axillary folds. There is facial flushing with circumhumeral pallor. A brawny desquamation occurs at 2 weeks, yielding fine flakes of dry skin. The diagnosis of scarlet fever is readily made on clinical grounds. Throat swabs usually culture Group A B hemolytic streptococci, although Group C may be cultured as well. Treatment with antibiotics is necessary to reduce the incidence of rheumatic fever and may ameliorate the clinical course of the disease, although the effect on other complications such as nephritis remains unclear. Penicillin and amoxicillin are antibiotics of choice. For penicillin-allergic patients, alternatives include cephalexin and clindamycin. Macrolide antibiotics remain an option, although resistance of Group A streptococci to macrolides is increasing. Erysipelas, or street Anthony's fire is cellulitis and lymphangitis of the skin caused by group AB hemolytic streptococci. Infection is frequently accompanied by fever, chills, malaise, headache, and vomiting. The rash is characterized by local redness, heat, swelling, and a raised, indurated border. There is marked involvement of the superficial dermal lymphatics. The rash starts as an erythematous plaque that rapidly enlarges by peripheral extension. At first, it is scarlet, hot, brawny, swollen, and tender. The edge is raised and sharply demarcated. The rash can vary in appearance from a transient hyperemia to intense inflammation, vesiculation, and bulla formation. The rash may have the appearance of an orange peel. The face was commonly the most frequent site, figure 142-20, of infection, but more recently, infections in children have been more common on the extremities. A skin wound, fissure, or ulcer may act as a portal of entry. The diagnosis is clinical, and cultures of the blood or from aspiration of the leading edge of the lesion are rarely helpful. A brief course of parenteral penicillin G-procaine is usually warranted because of the rapid advancement of the infection, the acutely toxic state of the patient, and the possibility of suppurative complications. Rapid clinical response is usually obtained. Cephalosporins, clindamycin, or trimethoprim sulfamethoxazole may be used in patients unable to take penicillin. Macrolides may be considered but are limited by increasing resistance. Other forms of cellulitis are treated in a similar fashion with parenteral or oral antibiotics as listed in Table 142-2. Cellulitis is most commonly caused by S. aureus. The affected area is usually erythematous, warm to palpation, and tender. Lymphangitis or regional lymphadenopathy may be seen. Once a mostly institutional issue, methicillin-resistant S. aureus has become increasingly prevalent as a community-acquired skin infection. Maintain a high suspicion for community-acquired methicillin-resistant S. aureus and be aware of local antibiotic sensitivities. If abscesses are present, they should be drained and cultures obtained. Small, less than 5 cm, pus collections can typically be treated with incision and drainage alone. Bedside US can localize the abscess and differentiate cellulitis from abscess when the clinical presentation is less clear. Figure 142-21. A petechial rash may be the presenting symptom of many viral infections or bleeding disorders or an indication of a very serious life-threatening disease due to bacterial infections such as Neisseria meningitidis. Figure 142-22. And meningitis is a gram-negative diplococcus and the causative agent of invasive meningococcal disease. Since the introduction in the United States of Haemophilus influenzae type B and pneumococcal polysaccharide protein conjugate vaccines for infants, and meningitis has become the leading cause of bacterial meningitis in children and remains an important cause of septicemia. Disease most often occurs in children 2 years of age or younger. The peak incidence occurs in children younger than 1 year of age. Another peak occurs in adolescents and young adults aged 16 to 21 years. Outbreaks continue to occur in communities and institutions, including child care centers, schools, colleges, and military recruit camps. However, most cases of meningococcal disease are endemic, with fewer than 5% associated with outbreaks. The incubation period is 1 to 10 days but usually less than 4 days. Because of the rapid progression from initial symptoms to death, it is important to recognize the first specific clinical symptoms, which can be early indicators of sepsis such as leg pain, cold hands and feet, and abnormal skin color, pallor, mottling. In approximately half of children, the first classic symptom of meningococcal disease is rash, which sometimes evolves from nonspecific to petechial to hemorrhagic over several hours. The petechial rash appears as discrete lesions 1 to 2 mm in diameter, most frequently on the trunk and lower portions of the body. The mucous membranes of the soft palate, ocular, and palpebral conjunctiva should also be examined for signs of hemorrhage. Petechiae may coalesce into larger porphyric and ecchymotic lesions. Figure 142-23. The petechiae correlate with a degree of thrombocytopenia and clinically are important as an indicator of the potential for bleeding complications secondary to disseminated intravascular coagulopathy. Early identification of a petechial rash is essential to allow for rapid intervention to prevent further progression to fulminant disseminated intravascular coagulopathy, meningitis, and sepsis. It is very important to perform a thorough physical exam as well as a close review of a full set of vital signs to look for early indicators of sepsis such as tachycardia or hypotension. The overall case fatality rate for meningococcal disease is 10% and is higher in adolescents. Children with a transient petechial rash who are well appearing do not need extensive testing. But the presence of petechiae in a febrile and ill-appearing child requires testing, especially a CBC to detect thrombocytopenia and leukocytosis. Cultures of blood and cerebrospinal fluid are indicated for patients with suspected invasive meningococcal disease. Cultures of a petechial or porphyric lesion scraping, synovial fluid, and other usually sterile body fluid specimens yield the organism in some patients. The priority in management of meningococcal disease is treatment of shock in meningococcemia and of raised intracranial pressure in severe cases of meningitis. Empiric therapy for suspected meningococcal disease is an extended-spectrum cephalosporin, such as cefotaxime or ceftriaxone. Once the microbiologic diagnosis is established, definitive treatment with penicillin G, 300,000 units kgd. Maximum, 12 million units d, divided every 4 to 6 hours, ampicillin, or an extended-spectrum cephalosporin, cefotaxime or ceftriaxone is recommended. Chemoprophylaxis is warranted for people who have been exposed directly to a patient's oral secretions through close social contact, such as kissing or sharing of toothbrushes or eating utensils, as well as for childcare and preschool contacts during the 7 days before onset of disease in the index case. Rifampin and ceftriaxone are the drugs of choice in children, and ciprofloxacin can be used for adult contacts. Scabies is caused by infestation with the Sarcoptes scabiei mite. The female burrows into the skin, where eggs are deposited and larvae hatch, resulting in the severe pruritus that characterizes the disease. There is typically a 4 to 6 week incubation period after exposure, which may occur at daycare, school, or within the home, and infestation occurs across all socioeconomic levels and is not a reflection of poor hygiene. The classic skin findings in older children and adults include a generalized eruption with linear burrows, papules, pustules, and even vesicles. Lesions show a proclivity for the hands, feet, and groin. Figure 142-24. In infants, lesions may be widespread, with involvement of the palms and soles, and hyperpigmented nodules may be noted in the axilla and diaper areas. Figure 142-25. Excoriations are common from scratching. The differential diagnosis includes impetigo, atopic dermatitis, insect bites, and drug reactions. A careful history evaluating for other family members or close contacts with similar symptoms should be sought and may provide a clue to the diagnosis, although, occasionally, even co-sleeping parents will deny symptoms. Testing is usually not necessary, because the diagnosis is made on history and physical alone, although scrapings of pustules may reveal mites on microscopy. Treatment consists of topical permethrin cream applied from the neck down. Infants may require application to the scalp and face, avoiding the mucous membranes, and left on for 8 to 12 hours before washing off. Lidocaine is contraindicated in young children due to neurotoxicity. For severe infestations, oral treatment with a single dose of ivermectin, 200 micrograms per kilogram, may be necessary. All linens and clothes should be washed in hot water. Treatment should include all family members to prevent recurrence of infestation. Antipyretics such as diphenhydramine may be useful. Families should be counseled but pruritus may continue for weeks despite successful elimination of infestation. As with scabies, infestations with the common head louse, pediculus humanus capitis, are common among children in school and daycare. Parents may bring children to the ED because of a diagnosis made at school or reports of an outbreak at daycare. Spread is by close contact, and hats and combs may act as fomites for transmission. The mites are more commonly found in long, straight hair and, therefore, are more common among girls than boys and less common among children with dark skin tones. Infestations may be asymptomatic and noticed by a caretaker or may present with scratching from pruritus. The diagnosis is confirmed by direct observation of live mites, although the presence of nits, egg sacs, may be considered a presumptive diagnosis. Nits are small, 0.3 to 0.8 mm, oval, white or yellow sacs that are found on hair shafts close to the scalp and often concentrated around the ears or nape of the neck. Figure 142-26. Treatment involves the use of pediculicides, careful grooming, hot water washing of linens and clothing, and co-treatment of close contacts. Several over-the-counter and prescription pediculicides are available. Permethrin, 1% lotion, is the most commonly used, NICS registered trademark, available without a prescription, although pyrethrins are also available over-the-counter, for example. RID registered trademark. Topical benzyl alcohol, 5% lotion, is also effective and safe for children as young as 6 months of age. The organophosphate malathion is available by prescription as a 0.5% lotion. Malathion is approved for children greater than 6 years of age and is applied to the hair and scalp, dry hair, left on for 8 to 12 hours, and washed out. Retreat in 7 to 9 days. Lidocaine shampoo is contraindicated in young children and pregnant women due to neurotoxicity. Retreatment after 7 to 10 days may be necessary with all of these agents, because none is completely effective. Careful removal of the nits with a fine comb, often supplied in over-the-counter products, is an important aspect of successful treatment. Shaving of the head is not necessary. Despite the name, erythema toxicum is a benign, self-limited rash that occurs in up to 50% of all newborns, typically in the first week of life. The etiology is unknown, and the rash spontaneously resolves over approximately 1 week, although new lesions may develop in the second week of life as well. Characteristic erythematous macules, 2 to 3 cm, develop on the face, trunk, and extremities, and may have central 1 to 3 mm pustules. Figure 142-27. The diagnosis is clinical, although right-stained scrapings of the pustules will reveal eosinophils if performed to differentiate erythema toxicum from impetigo or HSV. No treatment other than reassurance is necessary. Transient neonatal pustular melanosis is less common than erythema toxicum. It is most common in black infants. Transient neonatal pustular melanosis consists of 3 types of lesions: small pustules on the known erythematous base that may be present at birth, erythematous macules with a surrounding scale that develop as the pustules rupture and may persist for weeks to months, and hyperpigmented brown macules that gradually fade over several weeks to months. Figure 142-28. The diagnosis of transient neonatal pustular melanosis is usually based on the clinical appearance. Microscopic examination of a right-stained smear of the contents of a pustule may demonstrate numerous neutrophils and rare eosinophils. This can help differentiate it from the lesions of erythema toxicum, which contain mostly eosinophils. However, this is usually not necessary. Treatment is supportive, and full resolution is expected. Neonatal or baby acne affects up to 20% of infants and typically appears around the 3rd week of life. It results from stimulation of sebaceous glands by maternal hormones, and males are more commonly affected than females. Erythematous papules and pustules are commonly found on the face, although they may also occur on the trunk. Figure 142-29. The diagnosis is clinical, and no test. Seborrheic dermatitis affects neonates and infants as well as adolescents and is an inflammatory condition of unknown etiology, although genetic and environmental factors are thought to play a role. In newborns, the rash typically starts between 2 and 6 weeks of life and improves by 6 months of life. Lesions are greasy yellow or red scales and have a proclivity for the scalp, cradle cap. Figure 142-30, but may appear around the eyebrows, ears, cheeks, or neck and intertriginous areas of the body and diaper area. Rarely, seborrheic dermatitis can have more widespread plaques on the trunk and extremities and can be easily confused for atopic dermatitis. Unlike atopic dermatitis, atopic dermatitis, seborrhea is not usually pruritic and does not involve the extensor surfaces. The differential diagnosis includes atopic dermatitis, which should be considered when the onset occurs in the 2nd or 3rd month of life, when lesions are found to be weeping and pruritic, or with a strong family history of atopy, tinea capitis, and psoriasis. The diagnosis is clinical, and testing is usually not necessary. It is important to emphasize to parents that seborrheic dermatitis is typically self-limited. Treatment for cradle cap includes selenium sulfide containing shampoos or the application of mineral oil followed by washing and removal of scales with a fine-tooth comb. Infantile atopic dermatitis or infantile eczema is a chronic, recurrent inflammatory disorder of the dermis and epidermis of unclear etiology but with a strong genetic component. A complete discussion of the disorder is beyond the scope of this chapter, but atopic dermatitis is common throughout childhood and often presents in the first months of life. Triggers include excessive bathing or desiccation, heat, contact irritants, and allergens, foods and environmental. The disorder is associated with food allergies, asthma, and allergic rhinitis later in life. The infantile form typically manifests between 2 and 6 months of life, somewhat later than seborrheic dermatitis, for which it must be distinguished. Characteristic findings include xerosis, dry skin, and erythematous papular or papulovesicular lesions and plaques that may become excoriated or weep. The classic flexural distribution seen in older children, figure 142-31, is less common in infants in whom the face is most commonly involved, although diffuse involvement is possible, figure 142-32. The nose and diaper areas are typically spared. Lesions are usually pruritic, which, in infants, may manifest as fussiness. The differential diagnosis includes scabies and seborrheic dermatitis. A careful history, including affected caretakers and the family history of atopy, and the clinical appearance are usually all that are needed to make the diagnosis. Treatment involves counseling of parents to establish realistic expectations of probable recurrences. Therapy is aimed at identifying and eliminating triggers, reducing drying of skin, including limiting exposure to water with brief and infrequent bathing and minimal use of drying soaps, liberal application of emollients, for example. Vaseline registered trademark, symptomatic treatment of pruritus, for example. Diphenhydramine, and topical steroids for active inflammation. In general, ointments are more effective than creams, and low-potency steroids, see Chapter 248, initial evaluation and management of skin disorders should be used on the face and urogenital area, with medium-potency agents reserved for the trunk and extremities. Immunomodulators, such as tacrolimus ointment, are approved for children greater than 2 years of age, but should not be used in infants unless prescribed by a dermatologist. Occasionally, oral antibiotics or antivirals may be indicated for superinfected areas, for example, impetigo, eczema, herpeticum. Diaper rash is a common ED complaint that is specific to neonates and infants. Although rare disorders such as psoriasis, immunodeficiencies, and dietary insufficiencies, for example, zinc, biotin, may present with diaper rash. For all practical purposes, 2 forms of diaper rash compose the vast majority: contact, irritant, dermatitis and candidal dermatitis. Reducing substances in stool and irritants in the urine can cause a contact dermatitis when left in contact with the skin for prolonged periods of time or during diarrheal illness. The characteristic rash is erythematous, macular, or papular and has well-demarcated borders. The differential diagnosis includes perianal streptococcal infection, which is usually warm and macular and may be associated with desquamation. Treatment of contact diaper dermatitis includes good hygiene, air drying, and the use of barrier creams or ointments such as zinc oxide. Candidal diaper dermatitis results from superficial infection with Candida species that are ubiquitous in the infant GI tract. Typical lesions are erythematous with papular and pustular lesions and scaling around margins, figure 142-33. The classic finding is satellite lesions, which are small pustules beyond the margins of the main rash. The differential diagnosis includes atopic dermatitis, psoriasis, and contact dermatitis, although the diagnosis is usually made by clinical examination alone based on the characteristic scale and satellite lesions. Treatment is with topical application of antifungal agents, most commonly Nistadin cream, 100,000 units gram as a cream, powder, or ointment applied 3 times a day for 10 to 14 days, which may be applied in combination with barrier ointments, zinc oxide applied after Nistadin, and topical steroids, 1% to 2% hydrocortisone cream or ointment applied after Nistadin, but before zinc oxide if used, for severely inflamed lesions. Infants with candidal diaper dermatitis should be carefully examined for concomitant oral thrush. If oral disease is present, it should be treated with oral Nistadin in mixtures of 100,000 units ml. Use 2 ml 4 times a day in infants and 4 to 6 ml 4 times a day in children. Administer for up to 48 hours after resolution of oral lesions. Many medications commonly used by children can cause a significant exanthem for which parents will seek medical care. Often, the parents suspect an allergic reaction to the medication. There are a number of medications that are known to cause rash, including antibiotics and anti-inflammatory and antiepileptic medications. One study found that 45% of drug reactions were manifested in the skin. Most commonly, the rash appears as red macules with papules and can occur anytime after drug therapy is initiated, often 7 to 10 days. The rash can take longer to appear, especially with antiepileptic medications, and last 1 to 2 weeks. The reaction usually starts on the upper trunk or head and neck and then spreads symmetrically downward to the limbs, figure 142-34. The eruptions may become confluent in a symmetric, generalized distribution that spares the face. Mild desquamation is normal as the rash resolves. These rashes can sometimes be more morbilliform or even appear as the targetoid lesions of erythema multiforme. Occasionally these rashes can progress to Stevens-Johnson syndrome, toxic epidermal necrolysis, table 142-3, serum sickness, or drug-induced hypersensitivity syndrome. Drug-induced hypersensitivity syndrome involves a distinct triad of fever, rash, and systemic involvement of any internal organ. This should always be discussed with caregivers of children being discharged to home with a diagnosis of cutaneous drug rash as warning signs of worsening illness. Often management just includes discontinuation of the offending drug. Children with more severe skin findings or evidence of systemic involvement may require hospital admission. Treatment is mostly supportive with topical skin care, hydration, topical steroids if necessary, and oral antihistamines as needed. Until the early 1990s, erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis were classified as a continuum of the spectrum of disease. It is now appreciated that erythema multiforme is distinct from the more serious or even life-threatening Stevens-Johnson syndrome and toxic epidermal necrolysis, see Chapter 249, generalized skin disorders. Although all may be induced by the use of medications, such as barbiturates, penicillins, sulfonamides, NSAIDs, and phenothiazines, erythema multiforme in children is most commonly caused by infection, particularly herpes viruses and Mycoplasma pneumoniae. HSV1 and HSV2 account for 70% to 90% of all erythema multiforme cases. Erythema multiforme is rare under the age of 3 years old, affects boys more than girls, and does not favor a particular race or ethnicity. Erythema multiforme typically presents with an abrupt onset of rash, sometimes preceded by a burning sensation. Pruritus is usually absent. The characteristic lesions are described as target with 2 to 3 zones consisting of a dark, ruddy appearing center and a lighter colored area surrounding the center, figure 142-35. A red appearing outer ring is sometimes present. Lesions typically present as plaques and coalesce and frequently involve the palms and soles. When limited in distribution, the term erythema multiforme minor is often applied. Rarely there is involvement of the oral mucosa, in which case it is termed erythema multiforme major. Lesions last 1 to 3 weeks and may recur. Differential diagnosis includes urticaria, viral exanthem, hypersensitivity reaction, cutaneous drug eruptions, Stevens-Johnson syndrome, toxic epidermal necrolysis, and vasculitis. Treatment for erythema multiforme is supportive and includes reassurance, although recurrent disease associated with herpes virus has been treated with oral antivirals.